Good morning, everyone. Topic for today is drugs used in pregnancy and lactation other than psychotropics. And my moderator is Dr. Aslam. Introduction. Research on psychotropic medications during pregnancy is complicated by numerous factors, often involving complex ethical issues. Published literature on pharmacotherapy during pregnancy. Since many pregnancies are unplanned and many women with mental illness do not experience symptom improvement during pregnancy, it is important to be aware about the approaches to and risk associated with medication treatment during pregnancy. The management of mental illness in pregnancy requires a sound knowledge of the psychiatric diseases and perhaps importantly common sense. Hence, we need to rely on animal studies, case reports, and observational studies for the safety of the medication. The effects on the fetus to psychotropic exposure can be classified as teratogenicity, neonatal toxicity, and behavioral teratogenicity. Several classifications have been proposed for classifying the teratogenic risk of medications. Issues related to pregnancy. The first 4 embryonic weeks are described as the period of blastogenesis. It is the period of formation of blastocyst, implantation, and subsequently followed by the development of primitive stream. The next 4 weeks, that is from 5th to 8th week of gestation, is the period of organogenesis. It is duration this period that drug exposure in the mother has maximum effect on the outcome of pregnancy. The pharmacokinetics and pharmacodynamics changes during pregnancy include delayed gastric emptying, decreased albumin levels, decreased drug protein binding, increased vascular volume, hence reduced serum level of drugs, enhanced hepatic metabolism, and increased renal clearance, all of which can be significantly affect drug levels in the body. The fetus has low level of drug binding to the plasma protein, immature hepatic metabolism, a relatively permeable blood-brain barrier, and difficulties in transporting drug metabolites back to the maternal circulation, combined with the reduced ability of the fetus to metabolize drugs to produce higher drug concentrations in the fetal than maternal blood. Hence, at one end, adequate levels of medications have to be maintained in the maternal serum. At the same level, it has to be less in the fetal circulation. During pregnancy, the placenta serves several critical physiological functions. Among these is an important barrier role to minimize fetal exposure to the drugs taken by the mother and the other chemicals in the maternal environment. The fetal placental circulation is established by 21 days gestation and is fully formed by the end of 4th month of gestation. The protective role of the placenta as a barrier and for the removal of end products of metabolism is vital, as the fetal hepatic and renal system has immature and insufficient metabolic and excretory capacity. There has been a decline in birth defects mainly due to introduction of ultrasound screening as a part of routine prenatal care and followed by therapeutic termination of pregnancy. So FDA categorization of drugs in pregnancy, we have 5 categorization: A, B, C, D, X. A, controlled human studies show no risk, which includes vitamin B, C, D, E, folic acid, etc. Category B, no evidence of risk in humans. Examples, paracetamol. Category C, risk cannot be ruled out, most drugs. Category D, positive evidence of risk, which includes antiepileptics. And category X, contraindicated in pregnancy, like teratogenic drugs. Drugs which can be used during pregnancy. Nausea and vomiting. During nausea and vomiting, we can use metoclopramide. In hypertension, methyl-dopa. During cough, we can use codeine. During headache, paracetamol, codeine. In anticoagulants, we can use heparin S and C. During constipation, milk of magnesia we can use. And in anti-asthmatic drugs are beta-agonists, glucocorticoids, cardiac drugs, digoxin, anti-malarial drugs, chloroquine, antimicrobial drugs, penicillins, antihelminthics, anti-migraine drugs like ergotamine, anti-diabetic drugs, purified insulin, heartburns, non-systemic antacids we can use. In an allergic rhinitis, we can use glucocorticoids. And drugs during lactation, breastfeeding.
Where have you taken this course for disease condition drugs that can be used? Because benzodiazepines are X. First trimester, they're not. Whether you have said it, okay. First and second trimester, and said benzodiazepines cannot be given in first trimester. आपने कहाँ से लिया सोर्स कहाँ का है कौन सी बुक से
सर जो मेरे पास बुक थी ना उसमें थ्योरेटिकल था बट ये हमें मतलब
नैरो गलत है you're wrong. Benzodiazepine is class X. Steroids can probably reduce benzodiazepine second trimester of physical therapy कर सकते हैं, but very second third trimester में can go sedation and maybe अगर ठीक है. अभी तो I think Dr. Aish did a seminar on this. Narrow is not a good source of information.
Drugs during lactation. Breastfeeding mothers should avoid taking drugs if possible. When drug therapy is necessary, the mother should avoid contraindicated drugs and drugs that suppress lactation. When drug treatment is necessary, the safest known alternative should be used. Drug pass into milk by passive diffusion of free and unionized form. They are distributed within aqueous protein and lipid phase of milk. So drugs which are highly lipid soluble with low protein binding and unionized at physiological pH achieve high concentration in milk. Nursing infants can ingest significant amount of drugs if it was present in breast milk in high concentration. Drugs which suppress or inhibit lactation, bromocriptine, estradiol, oral contraceptives, levodopa, etc. Drugs which are hazardous to the infants, large doses of alcohol, caffeine, theophylline. Drugs which are absolutely contraindicated in nursing mothers.
This is information that is not of. So you should take help of the monitors and get information from reliable sources. This is okay. Next slide. You should contact your whatever moderator and get some books. So category wise and week yes and moderator. You are the moderator. Okay. So please contact your moderators. Okay. One of the main reasons why we do this seminar is so that people know how to collect information from reliable sources. Okay. So that you don't embarrass yourself when you go out and say things. So if you are saying something like anybody can come ask you for information, कोई news reporter आ जाएगा, देगा. So information तो पता नहीं, ये तो बहुत important चीज है. ठीक है? Okay. तो दिखाया था आपने कॉन्ट्रैक्ट को क्या था कितने मेरे पास बताया था कहाँ से बनाया?
Good morning, all. Today, my topic is reaction to severe stress and adjustment disorder. And my moderator is Dr. Anusha. History. These disorders include post-traumatic stress disorder, acute stress disorder, adjustment disorder. They can arise from experiences in war, torture, natural catastrophes, assault, rape, and serious accidents. Early psychoanalytical writers, including Sigmund Freud, noted a relationship between neurosis and trauma. In World Wars I and II, these disorders were given various names, including battle fatigue, shell shock, and shoulder's heart. Increasing documentation of mental reactions to the Holocaust, to a series of natural disasters and assault, contributed to the growing recognition of a close relationship between trauma and psychopathology. Now we'll come to introduction of stress. Under stress, a general adaptation syndrome develops. According to Hans Selye, adrenal cortical hormones are responsible for the physiological reaction. It has 3 stages: arousal, resistance, and exhaustion. So this is a diagram showing 3 stages of general adaptation syndrome. The first is alarm reaction, the second is resistance, and the third is exhaustion. Alarm reaction is generally general arousal caused by increase of adrenal glands reaction. So there was an article. So last alarm reaction, the general arousal caused by increase of adrenal glands, reaction of sympathetic nervous system. If a stressor is not removed, organism moves to resistance. Arousal subsides because of decrease in adrenal output. Counter reaction of parasympathetic nervous system. If a stressor is not removed, organism moves to exhaustion. General arousal of stage 1 reappears. Powerful parasympathetic response opposes arousal. If a stressor is not removed in time, death occurs. So this is a sir.
How many people have died of stress?
Sir, either the person will in illness, severe illness.
Just be there. कहीं को पढ़ा आपने कि PTSD से डेथ हो गया और जोन में रहा यूक्रेन में बहुत चल रहा है स्ट्रेस से कितने लोग मर गए चल आगे.
So this is a graph showing general adaptation syndrome. Now coming to hypothalamo-pituitary adrenal axis, HPA axis is under overdrive in stress and depression. Raised on hippocampus. When stress goes on for a long time, it can change brain's functioning and abilities, which can ultimately lead to mental health problems on the long run. Now coming to etiology part, first is stresses. These can arise from experiences in war, torture, natural catastrophes, assault, rape, serious accidents, for example, in cars or in burning buildings. Persons re-experience the traumatic event in their dreams and their daily thoughts. Risk factors: presence of childhood trauma, inadequate family or peer support system, recent stressful life changes, genetic vulnerability to psychiatric illness. Psychodynamic factors include traumatic events can resonate with childhood traumas, inability to regulate affect can result from trauma. Common defenses used include denial, minimization, splitting, dissociation, and guilt. Cognitive behavioral factors. The affected persons cannot process or rationalize the trauma that precipitated the order. They continue to experience the stress and attempt to experience it by avoidance techniques. Biological factors include non-adrenergic system, opioid system, and corticotropin releasing factor and the HPA axis. So this is the diagnostic criteria of acute stress disorder. According to DSM-5, its name is acute stress disorder, but according to ICD-10, it is acute stress reaction. The duration in acute stress disorder is 3 days to less than 1 month following exposure to trauma. And according to ICD-10, symptoms arise transiently in response to emotional or physical stress and usually resolve within hours or days. So the symptoms in DSM-5 are history of exposure to repeated exposure, witnessing in person, learning of occurrence in close acquaintance, actual certain death, severe injury or sexual trauma. Symptoms in the following categories: intrusion, negative mood, dissociation, avoidance, and arousal. In ICD-10, its name is acute stress reaction. Symptoms arise transiently in response to emotional or physical stress or usually resolve within hours or days. Symptoms include cognitive delays, narrowed attention, difficulties with comprehension, disorientation. Autonomic symptoms of panic may be followed by a further withdrawal from the situation or possible agitation, may have partial or complete amnesia related to the event. Now coming to adjustment disorders. By definition, a stressor precipitates an adjustment disorder. The severity of the stressor or stressors does not always predict the severity of the disorder, but the stressor severity is a complex function of degree, quantity, duration, reversibility, and environment. Stressors may be single, such as death of a loved one, divorce, losing a job, or medical illness. Alternatively, they can be combination of any of these. Psychodynamic factors. The understanding of...
Okay.
The understanding of adjustment disorders. So this is the diagnostic criteria of adjustment disorder. Yeah,
क्या है और इसमें okay. Go to the first slide. आपका टाइटल क्या था?
Sir, there was an introduction part of
reaction to severe stress and remember giving this topic. Our whole day you can cover it, not your fault. Next slide, please. Okay, so these are three different disorders: post-traumatic stress disorder, acute stress disorder, and adjustment disorder. So we can, like PTs can present one seminar on each of these topics for 1 hour. It is very difficult to summarize it right. Okay, then like these three topics you talk for 5 minutes. These are different disorders, right? So stress disorders, they are differentiated on the intensity of stress and the symptoms. Okay. For example, adjustment disorder. So it is usually in milder lifetime adjustments, like changing from home to some places. In that adaptation can be okay. Like getting a divorce, moving from one city to another, even something like marriage can be. You have to adjust the use of the way. Huge stress disorder, huge stress, but not very severe. PTSD that the stress is such severe that either the person's life is in danger. Okay, so he is in danger of losing his life, or his physical or psychological entity, losing a limb. So somebody shooting at somebody, okay, somebody involved in an accident, somebody in a war. That is PTSD. PTSD के लिए जो स्ट्रेस है वो एडजस्टमेंट डिसऑर्डर नहीं कर पाएगा. एडजस्टमेंट डिसऑर्डर के लिए अलग होगा. These are all three different disorders. And they similarly they cause different symptoms. The management is different. ठीक. एक etiology है ना. Very easy to say that ठीक है, ये इसकी जो दिए थे क्या था ना टॉपिक बोला है ओनली तो कहाँ का कौन किसने करी नहीं किए even has topic. What topic is in give is that simply the category what are the different categories? That is it. Or then there can be categorization of stress or the SPX's response to stress. Adjustment disorder again. There is some confusion. ठीक है बताओ.
Good morning to all
Have
today.
you understood what is adjustment? क्या होता है?
It is an emotional stress. सर अगर कोई पेशेंट चेंज करता है इन्वायरमेंट, जैसे अगर होम से हॉस्टल आता है तो जो एडजस्ट करने में उस प्लेस को उस इन्वायरमेंट. Good morning to all today.
This again is a topic for whole seminar, 1 hour seminar for PG. ठीक है, okay.
Overview, introduction to adjustment disorder, stressor, diagnostic criteria, differential diagnosis and management. It is the development of clinical significant emotional or behavioral symptom in response to an identifiable psychosocial stressor. Adjustment disorder are often labeled as waste basket diagnosis, that is residual diagnosis, referring to the fact that it is rather a specific diagnostic category or a wildcard diagnosis when no other disorders seem appropriate. Conceptually, adjustment disorder lies in the middle ground on a continuum between the normal stress response and pathological reaction. The differentiation of a normal response to a stressor and dysfunctional stress coping is based on the severity and the duration of symptom or impairment and personal factor into account. Type of stressor: single, example divorce, loss of job; multiple, marked business difficulty and marital problem; recurrent, seasonal business crisis; continuous chronic illness, living in property. It may affect single individual, entire family, larger group or community, example natural disaster. Some stressors may accompany specific developmental event, example going to school, leaving paternal home, getting married, becoming a parent, and retirement. Stressors for adults are ending up of a relationship, marriage, losing or changing job, death of a loved one, developing a serious illness, being a victim of crime, having an accident, undergoing a major life changes, living through a disaster. Then stressors for children and adolescents are divorce or separation of parent, moving to a new place, birth of a sibling, illness of either the child or a loved one, loss of a pet, problem in school, family conflict or sexuality issue. Diagnostic criteria for adjustment disorder. ICD-10 F43.2, according to it, the diagnostic requirement, the onset is usually within 1 month of the occurrence of the stressful event or life changes, and the duration of symptom does not usually exceed 6 months, except in the case of prolonged depressive reaction. If the symptom persists beyond this period, the diagnosis should be changed according to the clinical picture present. Normal bereavement reaction appropriate to the culture of the individual concerned and not usually exceeding 6 months in duration should not be recorded here, but by the court, such as J 63.4, disappearance of death of family member, or J 73.3, stress not elsewhere classified. Grief reaction of any duration considered to be abnormal because of their form or content should be coded, and those that are still intense and last longer than 6 months as prolonged depressive reaction. Diagnosis depend on a careful evaluation of a relationship between a form, content, and severity of symptom, previous history and personality, stressful event, situation, or life crisis. The presence of this third factor should be clearly established, and there should be a strong, through perhaps presumptive, evidence that the disorder would not have arisen without it. If the stressor is relatively minor, or if a temporal connection cannot be demonstrated, the disorder should be classified elsewhere according to its presenting feature. Subspecifier: F43.20 brief depressive reaction, F43.21 prolonged depressive reaction, F43.22 fixed anxiety and depressive reaction, F43.24 with predominant disturbance of conduct, F43.23 with predominant disturbance of other emotion, F43.25 with mixed disturbance of emotion and conduct, F43.28 with other specified predominant symptom. Differential diagnosis. Differential diagnosis of adjustment disorder are major depressive disorder, brief psychotic disorder, generalized anxiety disorder, somatic symptom disorder, substance-related disorder, conduct disorder, antisocial personality disorder, and post-traumatic stress disorder. Then management for adjustment disorder. We have two management for adjustment disorder, non-pharmacological and pharmacological. In non-pharmacological, based on the understanding that this disorder developed from a psychological reaction to a stressor and the stressor need to be identified, described, and shared with the patient. Pharmacological approach is to provide intervention for the symptomatic presentation despite the fact that it does not reach threshold level for a specific disorder on the account that it is associated with the impairment and treatment is effective for the patient. Non-pharmacological intervention. The majority of therapeutic intervention to adjustment disorder, three broad components in common. First, psychological intervention aim to enable the individual to reduce or remove the stressor. Second, intervention try to enhance the coping ability with the stressor and maximize adaptation. Third, symptom reduction and behavior changes is another important goal to reduce distress and improve functioning in the long run. Then we have step-up care approach for adjustment disorder, in which step one, we do watchful waiting, active monitoring, example, supervising by a general practitioner or a nurse. Then in step two, low intensive psychological intervention, example, bibliotherapy, behavior activation, and mental health intervention. Then in step three, we do psychotherapies and or pharmacotherapies as outpatient care, example CBT, psychodynamic therapy. Then in step four, we do psychotherapy and or pharmacotherapy as inpatient care, crisis intervention, example psychiatric hospitals. Pharmacotherapies is used as supportive treatment in adjustment disorders. Psychotropic medication has been used in medically ill, terminally ill, and in patients who have been refractory to verbal therapies. Antidepressant therapy, if there is no benefit from 3 months of psychotherapy or other supportive management. Psychotherapy combined with benzodiazepine may be helpful, especially for patients with severe life stresses and a significant anxious component. TCA were recommended in place to benzodiazepine in patients with current or past heavy alcohol use because of greater risk of dependence in this patient. These are my references. Thank you.
Excellent. I think if you get a long question or adjustment disorder, whatever is presented, you will definitely get more than 15 minutes. So, आपने कब दिखाया अपने मॉडरेटर को?
सर 1 वीक पहले दिखाया था और फिर कल से दोबारा.
ठीक है, this is very good app. Although the topic is postgraduate, still the information is correct. What is there? Just very good.
Thank you.
Good morning. My topic is acute stress reaction. My name moderator is Dr. Sata. Overview, introduction, etiology, risk factors, pathophysiology, evaluation, treatment and management, and prognosis. Introduction. Acute stress disorder, first outlined in 1994 at DSM-4, explains acute stress reaction that occurs in no less than 3 days and no more than 4 weeks. ASRs that extend for a period of more than 4 weeks can meet the criteria for post-traumatic stress disorder. DSM-5, in DSM-5, ASD was moved from anxiety disorders to trauma and stressor-related disorders. Dissociative symptoms are no longer a requirement for the diagnosis of acute stress disorder. Etiology: 20 to 90% of the general population exposed to extreme stressful events in life, only 1.3 to 11.2% of them develop ASD develop long-term symptomatic disease such as PTSD. It is explained by fear conditioning, a form of Pavlovian learning. When a traumatic stimulus, example explosion, occurs together with a neutral stimulus, example smell or context, example nighttime, in the future encounters of the neutral stimulus or a context, the brain and the body exhibits the same fear responses even in the absence of traumatic stimulus. Most healthy people adapt to fear conditioning by extinction learning, that is gradual reduction in response to traumatic stimulus. If this mechanism fails, the patient continues to re-experience the fearful symptoms of the initial traumatic events. Evaluation: ASD is a psychiatric disorder, but still can have physiological manifestations like tachycardia and abnormal functional MRI. Diagnosis is clinical and is based on history and physical examination. Careful behavior observation and careful listening to the patient's narrative are of immense value. DSM defines ASD criteria as following: A, being exposed to a traumatic event, either physically, sexually, or mentally. When having more than 8 of the following symptoms clustered in 5 categories. First one is intrusions, that is distressing memories of the traumatic events, repetitive dreams related to the event, enactment, that is flashbacks, intense or prolonged mental or physiological distress in response to events, reminding the patient of actual events. Negative mood, the inability to be happy, feel successful, or feel loved. Dissociative symptoms, sense of being detached from self and emotions. Dissociative amnesia. Avoidance symptoms include avoidance of thoughts, memories, feelings about events, avoidance of external reminders of the traumatic event. Arousal symptoms involve sleep problems, irritability, and rage attacks. Highly and abnormally alert to surroundings, distractibility, unusually strong reflexive reaction to sudden events in environment. CDE constitutes of duration of the symptoms should be between 3 days and 4 weeks and cause significant functional impairment and not related to substance use or other medical conditions to meet the criteria for ASD. Treatment and management. First is general measures, that is patient safety, emotional support by explaining the prognosis, course, and coping skills. Practical support, follow-ups, regular visits for 6 months for all the patients are recommended. Evaluate patient for suicidality. Psychotherapy, treatment of choice is unique form of cognitive behavior therapy called trauma-focused CBT. Pharmacotherapy, minimal evidences of pharmacotherapy are there, and most of the recommendations come from research on PTSD. Serotonin reuptake inhibitors, that is sertraline and paroxetine. Serotonin and non-epinephrine reuptake inhibitors, venlafaxine. Second generation antipsychotics, quetiapine and risperidone. Benzodiazepines, beta blockers, and alpha-1 selective adrenergic blockers, prazosin. Electroconvulsive therapy, a known side effect of ECT, that is memory disruption, could be used to help patients with severe post-traumatic stress disorder. Prognosis, strongly associated with later development of PTSD. According to DSM-5, PTSD remission occurs within 3 months, so it is recommended to continue pharmacotherapy for more than 6 months. ASD patients are 24 times more likely to die from a suicidal attempt, and mood disorders and substance use disorders are common in such patients. So these are
We need to like postgraduate social stress reaction, ACT and DSM is great.
Good morning, everyone. The topic for my presentation is post-traumatic stress disorder. My moderator is Dr. Abhijit ma'am. Overview, definition and introduction, epidemiology, etiology, clinical features, diagnosis, course and prognosis, and treatment. Introduction. Increased stress and anxiety following exposure to a traumatic or stressful event. Traumatic or stressful event may include being a witness or being involved in a violent accident or crime, military combat or assault, being kidnapped, being involved in natural disaster, being diagnosed with a life-threatening illness, or experiencing systemic physical or sexual abuse. The person reacts to the experience with fear and helplessness, persistently relives the event, and tries to avoid being reminded of it. The event may be relived in dreams and walking throughout flashbacks. Epidemiology. The lifetime incidence of PTSD is estimated to be 9 to 15%, and the lifetime prevalence of PTSD is estimated to be about 8% of general population. Although an additional 5 to 15% may experience subclinical form of the disorder, the lifetime prevalence rate is 10% in women and 4% in men. According to the National Vietnam Veteran Readjustment Study, 30% men develop full-blown PTSD after having served in a war, and an additional 22.5% develop partial PTSD, falling short of qualifying for the disorder. Etiology, stressor, risk factor, psychodynamic factor, cognitive behavioral factor, and biological factors. Stressor. Stressor is the prime causative factor in the development of PTSD. Not everyone experiences the disorder after a traumatic event. The stressor alone does not suffice to cause the disorder. The response to the traumatic event must involve intense fear or horror. Clinicians must also consider individuals' pre-existing biological and psychosocial factors and events that happened before and after the trauma. Risk factors. Even when faced with overwhelming trauma, most persons do not experience PTSD symptoms. The National Comorbidity Study found out that 60% of males and 50% of females had experienced some significant trauma, whereas the reported lifetime prevalence of PTSD, as mentioned earlier, was only about 8%. Similarly, events that may appear mundane or less severe catastrophic to most persons can produce PTSD in some. Predisposing vulnerability factors in post-traumatic stress disorder. Presence of childhood trauma, borderline, paranoid, dependent, or antisocial disorder traits, inadequate family or peer support system, being female, genetic vulnerability to psychiatric illnesses, recent stressful change in life. Psychodynamic factors. The psychoanalytic model of the PTSD hypothesizes that the trauma has reactivated and previously quiescent, yet unresolved psychological conflict. The revival of the childhood trauma results in regression and use of defense mechanism of repression, denial, reaction formation, and undoing. Cognitive behavioral factors. The cognitive model of PTSD posits that affected person cannot process or rationalize the trauma that precipitated the disorder. They continue to experience the stress and attempt to avoid experiencing it by avoidance techniques, consistent with their partial ability to cope cognitively with the event. Persons experience alternating periods of acknowledging and blocking the event. The attempt of the brain to process the massive amount of information provoked by the trauma is thought to produce these alternating periods. The behavioral model of PTSD emphasizes two phases in its development. First, the trauma, the unconditioned stimulus that produces a fear response, is paired through classic conditioning with a conditioned stimulus. Second, through instrumental learning and conditioned stimuli elicit the fear response independent of the original unconditioned stimulus, and persons develop a pattern of avoiding both these conditioned stimulus and the unconditioned stimulus. Some persons also receive secondary gains from the external world, commonly monetary compensation, increased attention or sympathy, and the satisfaction of dependency needs. These gains reinforce the disorder and its persistent. Biological factors. Noradrenergic system. Patients with PTSD-like symptoms exhibit nervousness, increased blood pressure and heart rate, palpitations, sweating, flushing, and tremors associated with adrenergic drugs. Studies found that increased 24-hour urine epinephrine concentration in veterans with PTSD and increased urine catecholamine concentration in sexually abused girls. About 30 to 40% patients with PTSD report flashback after UVB administration. Such findings are strong evidence for altered function in the noradrenergic system in PTSD. Opioid system. Abnormality in the opioid system is suggested by low plasma beta endorphin concentration in PTSD. Combat veterans with PTSD demonstrate a naloxone reversible analgesic response to combat-related stimuli, raising the possibility of opioid system hyperregulation similar to that of the HPA axis. One study showed that nalmefene, an opioid receptor antagonist, was of use in reducing symptoms of PTSD in combat veterans. Corticotropin releasing factor and the HPA axis. Studies have demonstrated low plasma and urinary free cortisol concentration in PTSD. More glucocorticoid receptors are found on lymphocytes, and challenge with exogenous corticotropin releasing factor yields a blunted corticotropin response. Further suppression of cortisol by challenge with low-dose dexamethasone is enhanced in PTSD. This indicates hyperregulation of the HPA axis in PTSD. Recently, the role of hippocampus in PTSD has received increased attention, although the issue remains controversial. Animal studies have shown that stress is associated with structural changes in the hippocampus, and studies of combat veterans with PTSD have revealed a lower average volume in hippocampal region of the brain. Structural changes in amygdala, an area of the brain associated with fear, has also been demonstrated. Clinical features. Individuals with PTSD show symptoms in 3 domains: intrusion symptoms following the trauma, avoiding stimuli associated with the trauma, and experiencing symptoms of increased automatic arousal, such as an enhanced startle. Flashbacks, in which the individual may act and feel as if the trauma were reoccurring, represent a classic intrusion system. Other intrusion symptoms include distressing recollections or dreams, and either physiological or psychological stress reaction to exposure to stimuli that are linked to trauma. An individual must exhibit at least one intrusion symptom to meet the criteria of PTSD. Symptoms of avoidance associated with PTSD include efforts to avoid thoughts or activities related to the trauma, anhedonia, reduced capacity to remember events related to the trauma, blunted events, feelings of detachment or derealization, and a sense for a foreshortened future. Symptoms of increased arousal include insomnia, irritability, hypervigilance, and exaggerated startles. Diagnosis. The DSM-5 criteria for PTSD specify that the symptoms of intrusion, avoidance, alteration of mood and cognition, and hyperarousal must have lasted more than 1 month. For patients whose symptoms have been present less than 1 month, the appropriate diagnosis may be acute stress disorder. This is the DSM criteria for diagnosis of PTSD. Course and prognosis. PTSD usually develops treatment. When a clinician is faced with a patient who has experienced a significant trauma, the major approaches are support, encouragement to discuss the event, and education about a variety of coping mechanisms, example, relaxation. In encouraging persons to talk about the event, it is imperative that the clinician allow the person to proceed at his or her own pace. To press a person who is reluctant to talk about the trauma into doing so is likely to increase rather than decrease the risk of developing PTSD. The use of sedative hypnotics can also be helpful in some cases. Pharmacology. SSRIs such as sertraline and paroxetine are considered first-line treatment for PTSD owing to their efficacy, tolerability, and safety ratings. SSRI reduce symptoms from all PTSD symptoms clusters and are effective in improving symptoms unique to PTSD. Buspirone is a serotonic and may also be of use. The efficacy of imipramine and amitriptyline, 2 tricyclic antidepressant drugs, in the treatment of PTSD is supported by a number of well-controlled clinical trials. Patients who respond well should probably continue the pharmacotherapy for at least 1 year before an attempt to withdraw the drug. Some studies indicate that pharmacotherapy is more effective in treating depression, anxiety, and hyperarousal than in treating avoidance, denial, and emotional numbing. Other drugs that may be useful in treatment of PTSD include monoamine oxidase, anticonvulsants. Psychotherapy. Psychotherapeutic interventions for PTSD include behavioral therapy, cognitive therapy, and hypnosis. Many clinicians advocate time-limited psychotherapy for the victims of trauma. Such therapy usually takes a cognitive approach and also provides support and security. The short-term nature of psychotherapy minimizes the risk of dependence and chronicity, but issues of suspicion, paranoia, and trust often adversely affect compliance. Therapists should overcome patients' denial of the traumatic event, encourage them to relax, and remove them from the source of stress. Patients should be encouraged to sleep using medication if necessary. These are the references. Thank you.
That's all.